Hello guys, welcome to Therapy Live, welcome to the afternoon. I'm just going to give it a few minutes just for everyone to make sure they're in. So let's give it 10 more seconds. Good, I hope everyone's enjoying the day. Okay, so I think we'll take it away. I'm delighted to introduce our two speakers for this talk, both whom are incredible osteopaths and educators. Andrew Macmillan is an osteopath working in advanced practice, whose research is around rheumatology and practice education. And Oliver Thomson, associate professor, whose research interests include critical analysis of MSK professions, as well as qualitative research. Outside of work, I know they're both big lovers of the gym, and I think Oliver has a particular interest in antique lamps. So there's that. So maybe you can tell us more about that at the end. So, but before we hand over to them, a quick word from our sponsor, which for this session is MSK Mag. Have you checked out the best thing to happen to CPD accessibility in the last decade? MSK Mag brings the written word back to MSK CPD. Using Physio Matters editing team, content creation experience, and excessive expert access to maximize quality, it really is amazing. It reads easily, looks fantastic, but that's not all. It's also in audio and is delivered directly to you via an email and an app. Click the link to read the latest, and I'm sure you won't regret it. So that's it from me, guys. I'll hand over to both of you. Take it away.
Great. Hello, everyone. Thanks, Rob, so much for that. And it's appropriate that MSK Mag is the sponsor of this talk, because it was really the opportunity for us to write the paper that we're going to talk about in regards to what's right with osteopathy. Andrew and I were just going to say thank you to MSK Mag and Jack Chu and his team for giving us this opportunity to discuss the paper and some of the context around it, and hopefully touch on some of the implications for MSK practice more broadly. So we welcome this opportunity. As Rob said about me, he called me an excellent osteopath. I'm not quite sure what that means, but I am an osteopath by kind of regulatory legal title. I work in practice a couple of days a week in London in a bit of a MSK multidisciplinary context. Academic, I do a bit of research, quite a bit of research and teaching. And as I said, most of my interest is around kind of critically thinking about some of the big questions that face MSK practice and my own profession, osteopathy, more broadly. And here's Andrew.
And yeah, so as Rob mentioned, I'm an osteopath. I work primarily in an advanced practice role in a rheumatology setting and an intermediate care setting within the NHS. I'm a reviewer for advanced practice for NHS England, so looking at the things like the FCP roadmaps and the new advanced practice masters coming into play. So that's just starting up. I work for the University College of Osteopathy as a senior research fellow, so I'm regularly researching and publishing on a range of things. As mentioned, my main research area is education, but I look at widening participation and increasing kind of access to healthcare education professions, as well as a bit on rheumatology, MSK imaging, and various clinical things as and when the opportunities come up. I've got quite a lot of teaching and educational management experience, having worked in a range of higher education institutions, as well as a bit of private practice osteopathy around it, as I'm sure many others do.
Great. So today we're going to talk to you about two papers, essentially. We've got to speak about the first paper before we speak about the main topic of our presentation. So Andrew and I, last year, I think last May, we wrote a paper called What's Wrong with Osteopathy? I've skipped 4 slides there. No, I haven't skipped no slides. Right. So we wrote a paper called What's Wrong with Osteopathy, which really was a response to a call for papers by the editor of the International Journal of Osteopathic Medicine, which sought to critically reflect, discuss the future of our profession, the big challenges facing it, and how we can make things or imagine things to be better. And we're going to kind of outline this paper first, so the second aspect of the talk makes sense. The What's Wrong with Osteopathy paper, which is conveniently titled WWWO from now on, was a critical opinion paper. It wasn't research in a purist sense, but rather drew upon existing theory, evidence, kind of policy for us to articulate some of the 5.
I think Ollie's cut out there, so I'm going to jump back in. So we highlighted some of the 5 areas that we thought were the biggest kind of challenges facing osteopathy or needed further discussion and consideration. Now, although this was a commentary paper, meaning it was our opinions and our thoughts, that's the reason we kind of had a little bio slide in here, is we think these were informed opinions based on other research we've done and being kind of an inside voice from the profession. So the aim was that osteopathy, as with lots of other MSK healthcare professions, has to sort of sing for its supper, justify what we do and how. And we thought that these calls should come from inside. We should be able to reflect on our own profession, what we do, where we're going potentially, so that we can withstand kind of scrutiny from external sources. The idea being a strong, robust profession is reflective and looks at what could be done better to enhance practice and ultimately the care of the people who use those services. So our motivation was to develop osteopathy in its stance and basically see what we could do better and highlight those areas. So what's wrong with osteopathy? We think that many of our considerations here may apply to other MSK healthcare professions, as I'm sure we're aware and have thought of the limitations within our own professions, whatever they may be. There's been similar calls recently within chiropractic, reflecting on some of the challenges they face, as well as some of the critical stances towards physiotherapy. So some of you may well be aware of Dave Nichols' work, like the end of physiotherapy or physiotherapy otherwise. And it's a similar sort of critical stance, looking at the core assumptions within the professions and what could be done differently for better care of people. And we know, as I've mentioned, with the advanced practice stuff coming in, there's lots of changes on the horizon within MSK professions. And what we did 10 years ago isn't necessarily what we do today. And we're trying to look ahead of what will these professions look like in another 10 years or 20, and where are we going? So the 5 areas that we kind of staked out and laid claim to is what's wrong with osteopathy, where it's weak theoretical basis. Now, this is looking at some of the purported mechanisms of treatment, as well as a lot of the sort of social cultural aspects of care, and saying that the underpinning deeper social theories around what we do aren't quite as developed. So thinking how we could make those more robust and further them. The inherent biomedicalism, which we'll expand upon, is kind of the biomechanical, anatomy-centric ways of viewing what we do, rather than care of people and the human experience of those using these services. So lots of rigid and sometimes tenuous connections with anatomy. Monointerventionalism, in osteopathy in particular, we're a very hands-on discipline. So osteopathy obviously is a profession rather than a set of treatments. But the vast majority of osteopaths, when surveyed, use manual therapy almost exclusively, and high velocity manipulations, sort of the grade 5 thrust techniques, are very frequently used. So we sort of had a little go at this in the terms of, if the only tool you've got is a hammer, everything looks like a nail, and what other things could we add to this, to our toolbox, to develop our care of the people who we see. Practitioner-centeredness, I'll let Ollie expand on more, because that ties in much more closely with his research work. But lots of his qualitative work around that, and consent and various things. The implausible mechanisms I've sort of mentioned with the mono-interventionalism, but the typical old-fashioned kind of bone out of place rhetoric around manipulation in particular, but all the way through to structure governs function as a principle of osteopathy, where we know from imaging findings that often they're poorly correlated with symptoms and pain. And in osteopathy, there's some rather absurd claims, particularly around some of the treatments directed at the cardiovascular system or the brain. And we picked out a few examples that we thought were the more extreme end of some of the claims made within the profession, which we see both on social media and within peer-reviewed formats. So I'll pass back to Ollie for a little outline of the practitioner-centeredness ones, if that's okay.
Yeah, great. Sorry, you lost me there for a minute. So we're going to just dive in quickly, if that's even possible, to do a deep dive, which is quick. As Andrew said, the weak theoretical basis with osteopathy, that was a limitation that we kind of articulated in the What's Wrong paper. And really, as Andrew said, it goes something like osteopathy has this kind of theoretical basis, which is largely rooted in kind of 1800s US heroic medicine, in kind of Missouri, curing people with all sorts of illnesses and diseases. And it was kind of viewed that a bit of a rub, a bit of manual therapy is probably better than seeing your local physician who would have poisoned you with mercury and all sorts of pretty crude surgical procedures. And so some of these observations that came from Andrew Taylor Still, who was the kind of founder of osteopathy, kind of just kind of through being handed down over time, have kind of formed this kind of body of knowledge, or this body of theory, which we argue as being pretty weak, pretty rudimentary, doesn't really draw upon kind of recent theoretical advances or philosophical advances, whether it's critical theory, phenomenology, and activism, the biopsychosocial model, all these different ideas. And so we really argue that this theoretical basis really is not fit for purpose in the current kind of social healthcare world that we find ourselves in. And so there's an opportunity for osteopathy to really draw upon recent theoretical advances to kind of advance practice. So that was our first kind of weak theoretical basis, or this weak philosophical basis within osteopathy. And the next one is tied to it, was this inherent biomedicalism. So, a kind of a claimed virtue of osteopathy and osteopathy is that they know the body really well, they know the anatomy, they can name all the muscles, the ligaments, how it all connects together. And osteopathic practice and education is kind of saturated with a biomedical discourse. Really, if you look at the weighting of different modules in education, it really is geared towards biomedical orientated topics. And that leads to a particular stance that the osteopath might take as being a kind of human engineer, diving into the kind of gubbin to the patient to manipulate, to correct, and to fix. And that seems to contrast with much more kind of person-centered, collaborative or empowering models of practitioner approaches. Andrew, anything here? You've done some work on this, I think.
No, I think that kind of covers it. We'll touch upon that when we get to the education bit as well, because that seems to be where most of the educational research around osteopathy is centered, is on better ways to do manual therapy, and in particular palpation, which is kind of disproportionately heavily weighted as opposed to some clinical reasoning and elements like that.
Yeah, and so our claim here is that osteopathy potentially backed the wrong horse. So to put all your eggs in the anatomical basket and say healthcare and wellness and suffering is really all about anatomy. And if we just know the anatomy, people will get better, or we can kind of manipulate literally and metaphorically the anatomy so that patients' health improves. It seems to be the case that what seems not to be the case, given what we know about imaging, pain, structure, all that kind of stuff. So, and with that, as I said, comes a kind of set of language games of having anatomy really pervade your discourse with patients, with colleagues, with professional promotion is kind of nasibic and really not consistent with much more an activist or biopsychosocial approach now. And you said he touched on mono-interventionism, which is a word we kind of made up, which is fine, I think, which is the kind of one-trick pony. Osteopaths are manual therapy, or rather the profession, its identity, its education is really built around a single intervention, which is doing stuff with your hands. And that's perfectly fine, but it just seems to us a very limiting and reductive approach to really base your practice, your identity around a single thing, which has questionable evidence around reliability, utility, effectiveness, etc., etc. And this idea that really treatment isn't treatment unless there's a hands-on component, we find annoying, to say the least.
Yeah, I think with this we called for, I think we said the judicious use of hands-on, hands-off, and hands-less. Yeah. So we're not necessarily arguing against manual therapy, and see it has a place in short-term symptom relief or as a communication tool with patients. So we've also highlighted some of the use of touch and hands-on as a strength or a potential strength. But it's the kind of use of clinical time. As those who work in the NHS will be well aware, there's an awful lot more exercise prescription, but that's geared towards empowerment, giving people the tools for self-care. We have good effects, we noticed through COVID, of doing some virtual sessions and cognitive reassurance and helping people understand what's going on and the meaning making of their sort of experience. So we're not saying it's totally wrong. We're saying there's other tools that may benefit, be used with, or other areas we should focus on essentially in practice as well, because it's incredibly disproportionately weighted in education and practice.
And as you said, the fourth limitation, or the thing that we felt was wrong, was this practitioner-centeredness, which really goes something like the kind of perceived expertise within osteopathy is about the clinician, the osteopath, knowing, accumulating more knowledge, perfecting, mastering more motor skills or manual therapy skills, and they are the kind of the positioning of the osteopath in the relationship with the patient is one of all knowing, all doing, probably all good as well, right? But it just seems to be an unequal patient relationship where it's the osteopath that has the skills to kind of feel around the patient's body, interpret all of that, make decisions or lead that decision making around the kind of treatment or management which is best for the patient. And there's evidence that osteopath at times can be practitioner centered, where really decision making is driven by the practitioner rather than a kind of sharing of decisions, or in some cases patients leading decisions. And then this really starts to kind of undermine the patient as a person. It really fails to develop connections with people, and rather connections with body and anatomy. The final one is kind of my favorite one, and it's not unique to osteopathy, this predilection for implausible mechanisms. This, as Andrew kind of alluded to, that there are some somewhat kind of sensible claims around how manual therapy or how the kind of assessment approaches that osteopaths use might work, those kind of putative mechanisms. There's also some pretty far out stuff which still doesn't seem to die. It continues and is perpetuated and taught as kind of postgraduate or CPD stuff. And so that's just we find that as a we're not quite sure what to do with that. I mean, some of it's just given that osteopathy's legal status in the UK and many parts of the world is a profession with ethical standards and standards around knowledge and evidence and claims. It does seem to be curious that some of these peculiar mechanisms or implausible mechanisms can be allowed to continue.
We find that's a very tricky one as well for the public, is you almost don't know what you're going to get when you see an osteopath. You may get someone who works in a very evidence-based sort of way, or all the way through to some of the rather alternative views and claims. So it's very difficult to define what practice looks like and what it is for the public and other professions. And we were sort of concerned with this as undermining the reputation of the profession and its status. So, yeah, the idea of some of the rather bizarre things being the perceived nature of what osteopathy is. That you see someone they may get some crystals out and unblock your chakras, for instance, as opposed to someone who works in a slightly different way to that. But as we say, these aren't unique to osteopathy necessarily. So we've picked some examples there of the activator technique, which is commonly used in chiropractic, or some of the traction-based techniques, which are now discordant with the evidence base that we have in some guidelines. I think that's one of your favourites, isn't it, Ollie, the kinesio tape on an elephant?
That's a good one. I think the manual therapy to the brain is also interesting. It's not, it's really, and this is an example where it's much more nuanced than just the crystals, which just seems like absolute, nonsense. But it's osteopaths using kind of a language around science and anatomy and physiology, and which on the face of it has some kind of plausibility, and to patients and to others might seem somewhat coherent, but actually diving into it, it really makes no sense at all from a kind of evidential or otherwise way.
And that can be from the really extreme claims all the way through to stuff like posture pain models that I'm absolutely early in my career guilty of that, of telling people that their back hurts because they're not standing right or they're not walking in a correct pattern. And we know now that those things are very poorly correlated with pain, symptoms, prognosis. So it goes from some of the sort of deeply held, fairly obvious on the face of them claims all the way through to some of the rather more bizarre ones that are easier to sort of point out.
And then we're going to have to whiz through this because we haven't got to what's right with. But the big question is that osteopaths really have these subjective stories about how they're interacting with patients, what's going on, their experience of them interacting with their hands. The big question is, what words can we use to try and, or what language can we use, what frameworks can we use to really articulate that so it matches the kind of biological reality. So it's one thing saying that you perceive this, to be able to palpate the cerebral spinal fluid when you put your hands on someone's head. Clearly, biologically, empirically, objectively, that isn't the case. So how do we resolve this tension? And that's a question we can't answer, and we're not going to answer it here. moving on to the kind of the tail end of the paper. So the paper, unsurprisingly, generated a bunch of responses. It was really well downloaded, which is great for, not for us, we don't get any more money, but it's great that people are just reading stuff. It's a good thing. I think this number of 7,000 downloads is probably at least double now. I'm guessing it's an old number. But like all these things, some people loved it, some people hated it. Both kind of formally, people responded to us through letters to editors, of which there's a kind of selection here, and others, contacted us or just shouted at us, from social media. Nonetheless, it was great that it stirred up some discussion. What we noticed about all of the real rebuttals was that people expected us to provide an alternative, or if this is wrong, what's right, which wasn't really our obligation. You can just write critical papers. Moreover, no one else seemed to write a paper which articulated the kind of virtues and kind of benefits, if you like, or positives of osteopathy. And so we just thought we would be less negative Nellies, be more positive Pollies. And thanks to Jack reaching out to us and MSK Mag, we will give the opportunity to write it ourselves.
Yeah, and with this, we thought it was a great opportunity to sort of promote some of the things we saw that were good within the profession, but to a wider audience. So the opportunity to present today to something that's more multidisciplinary. Typical journal formats are only available to those with institutional access. So UK osteopaths could access the What's Wrong paper, but the wider professions, it's just nice to be able to have the opportunity to explain a bit about osteopathy, what we do, its strengths to a wider audience as well. So we thought that was a great outlet for this.
And the important thing is that we weren't claiming that these strengths were in any way defining osteopathy or weren't apparent in other professions. They were just things that we felt the profession does reasonably well, and is some kind of platform to move on from. So the first one we kind of argued is that it's an organized profession. I mean, this is variable across the globe, given that in some parts of the world osteopathy is unregulated and it's not very organized, but in many parts of the world it is an organized, regulated profession. In the UK, it's regulated by law. There's around 6,000 osteopaths, and we've got one professional regulator, the GOSC. We've got one professional body or association, the Institute of Osteopathy, and one council for research. And in that case, it's kind of consolidated and tidy and well organized, and has led to us being part of the AHP family. We've also got the capacity for research leadership, and output is growing, which is a good thing. And we've got kind of standards of practice and regulatory standards and standards of ethics and conduct. So that's a really good thing. I mean, it sounds pretty basic, but it really is fundamental to any profession. Let's pause for you, Andrew.
Nothing really to add on that. I think that sums it up.
The next one is relationships into practice. So we're kind of contradicting ourselves because we said it was practitioner centered. But with that said, I guess it can both be true that osteopaths are deeply interested in patients' bodies, but at the same time, there's an opportunity to be deeply interested in patients and the relationships that they endeavor to develop with patients. And osteopaths have relatively long appointment times. There's at least in my practice, I've got 45 minutes to an hour, so I've got lots of time to potentially do effective therapeutic stuff. And so I guess the question for the profession is, what's the best use of that time? If it's just half an hour, 40 minutes of manual therapy, largely with little kind of social or psychological informed practice, then that's really not, we would argue, the best use of the time. But nonetheless, osteopaths are by and large interested in patients' experiences, their lives. They're often built into the communities. They've got kind of close contact there, and they offer an important service in many regards. You're saying quiet, you?
I'm saying quiet, rarely and uncharacteristically. So training and education, we really highlighted. This is supported by a variety of things. So subject benchmark statements from QAA, which I was fortunate enough to be involved in, as well as a scoping review I did on osteopathic education. So most osteopaths qualify with a degree or master's level qualification, so pre-registration masters, or MOST, which is an integrated masters. So they're well trained, and specifically with an MSK focus that meets a lot of the competency frameworks and some elements of sort of the advanced practice frameworks and others. So it's training to a high level, level 6 or 7 of the academic sort of standards in a regulated environment with sets of competence that must be met to progress. So we think that the standard of training in osteopathy is good.
Yeah.
It's safe and builds people towards being an autonomous practitioner. So osteopaths from day one can go and work by themselves, essentially. There's more and more opportunities to work in more structured development areas with mentoring, which we'd absolutely encourage. But they can have a base level of competence, which is great, and hopefully similar to other regulated professions. There's a lot of clinical experience in osteopathic training. Students typically start with clinical observations and clinical practice early in their career with a lot of practical skills, from examination of joints and MSK and neuro assessments all the way through to the treatment stuff, which gives a lot of opportunity to develop communication skills and clinical reasoning. And as I mentioned, a lot of focus on MSK, and typically undergraduate osteopaths are exposed to a range of conditions and a range of populations that they can then kind of progress their career in the direction. So it's quite a broad-based set of training that equips them for whatever future careers they may wish to go into. And very importantly, like with other MSK professions, it's safe. So osteopathy is generally very safe with very few serious adverse events. Obviously, there's controversy around certain techniques like C-spine manipulation, which is similar across the breadth of MSK professions. It appears from the available evidence, the risks of osteopathy are very low and very comparable to other similar professions. So dependent on techniques, transient symptomatic worsening or soreness after manual therapy is quite common, but typically quite short-lived. And actually, it appears from the available evidence I've read that doesn't particularly matter what types of technique are selected. So some people will feel a bit sore after treatment and examination, but that is also fairly similar with light touch techniques or almost placebo-type techniques, as well as the more robust sort of spinal manipulation type techniques. So we think it's good that people can see an osteopath and know that they're in safe hands, as it were, that there's screening for serious pathology as with other professionals, and they've been trained to that level, and it's unlikely to basically dramatically make things worse, which is good, particularly as history of things take effect.
The cheesy saved hands slogan, good one.
I missed that one. I quite liked it.
And the final benefit is the use of touch. And again, we made a case for mono-interventionism, so this reliance on palpation or the reliance on manual therapy and hands-on skills, and without really exploring to the same degree the other different therapeutic options, psychologically, socially, exercise-based. But nonetheless, it seems like hands-on or manual therapy is going to be part of osteopathy, whether anyone else likes it, whether we care, wouldn't like it to be so. So, but nonetheless, touching people and using kind of palpation, and it requires a bunch of kind of ethical, propositional, anatomical knowledge to be able to touch them in a meaningful and therapeutic way. And so if you're going to touch people, then osteopaths really are in a position to touch people, to use manual therapy, use palpation in a sensible way, to guide patients, to communicate with patients, to help reassure patients. There's ways to utilize kind of the traditional manual therapy skills in a different framework. I see there's a recent paper which has just been written, I think, by Roger Carey and colleagues, which really modernizes or brings forward manual therapy in a much more contemporary framework. So again, manual therapy shouldn't be taken away necessarily from osteopathy or osteopaths, but rather just to adopt it and utilize it within a different framework. Andrew.
Yeah, and like we say, I briefly mentioned something that's very valued by patients. It's often one of the reasons people come and see osteopaths in private practice, and often is a criticism leveled at other types of intervention that given of, they didn't even touch me. So being touched as part of examination, part of that communication sort of tool, it definitely has benefits, which we think are good. And osteopaths often develop high levels of psychomotor skills to have kind of nice therapeutic touch that feels pleasant, which we think is a good strength.
Yeah.
And then final slide from us before we move over to questions. So I hope you are ready to give us a grill. Just say thank you for listening and for attending this. We wanted to highlight some of the areas we think osteopathy could develop, as well as similar MSK professions, but as well highlight that we're not all doom and gloom. We're practicing osteopaths, we work in osteopathic education. We absolutely think there are things done well and things to develop further in all kind of healthcare generally, but in particular as osteopaths, we thought someone like ourselves should be the ones to level the strong critiques at the profession as a starting point to kind of enhance reflection and development of what we do.
Great, thanks all. Thanks, Andrew.
Brilliant. Thanks for that, guys. That was fascinating. And I think, as you both know, I'm a chiropractor. So I sit very, the questions which you guys propose are the similar questions that I have myself with my own profession, and it's spaced within kind of the MSK trifecta or the MSK kind of world. I guess what I want to tee it off by starting with was how, in your opinion, how wide is this problem? So if you look at the scope of osteopaths in the UK, is it 3,500? I think osteopaths kind of in the UK.
No, I think it's more like 6.
Oh, is it 6? Yeah. So yeah. So is it how on that? If you think of if you guys are as far right as you come in this spectrum of thinking, how many others are on that scale, and how big is it? Are most people in the middle ground? Are most people much further to the left, if you will?
I'd say the problem is we have quite poor data regarding practice. So the best available data we've got on the ways osteopaths practice is where we got the stats around the use of manual therapy and that side. But some of the more base considerations are just ingrained within education and within the professions. So there's elements where some of the rather less plausible mechanisms are taught in undergraduate syllabus and are part of that directly. But when we look at what is taught in curriculum reviews and things like that, some of the base assumptions of the profession around things like posture and the strengths of manual therapy or even palpation are just sort of taken for granted almost, that we can develop those skills more robustly and learn to master palpation for diagnosis, which the evidence doesn't support, but time spent teaching disproportionately weighs towards that, as does the research into teaching. So the short answer is we don't actually know how much it transfers to practice, but some of the deeper cultural associations within the profession, if you rounded up a group of osteopaths and asked them a question about palpation, I'm sure it's similar in chiropractic, potentially to a lesser extent in physiotherapy. But yeah, just some of those mechanisms, stand up straight or your back will hurt, is just taken for granted despite not having any robust proof behind it.
And I guess that's the scale, isn't it? There's talking about posture and its correlation with back pain, compared right up to palpation of the pituitary gland, through the skull. On that spectrum, there's two very different kind of potential problems there. Both potentially a problem, but the scale there is different, and the hubris that comes with a statement like some of the palpation techniques, I guess, is the problem. Do you feel that people attach themselves to these narratives because they don't have another narrative, or do you think that they genuinely, at their heart believe that they can palpate the pituitary gland, or is it just that confirmation bias that kind of, I wiggled this bit and the patient said they felt better, so it must be what I've done, that kind of post hoc fallacy?
I think it's difficult. I mean, I think there are other frameworks by which to make sense of these outcomes, and whether it's contextual effects or kind of placebo effects or various kind of expectation effects, therapeutic relationship. I mean, there are other ways to kind of explain some of the observations that osteopaths notice with the patients. But for many osteopaths, the kind of nuance and the detail and the fact that it occurs because of the pituitary is really crucial. I mean, it's not sufficient that when you put your hands on someone's head and you do some cranial, I'm picking out cranial here, but whatever, you put your hands on someone, it's not sufficient enough that it's due to relationships or reassurance or regression to the mean, all these other things. No, it's got to be that. So that I think the mechanisms are tied to a sense of identity, that it kind of, the pituitary thing, as an example, needs to be true for osteopathy to be true. That osteopathy cannot just be about shared decision making and therapeutic alliance and contextual effects. It needs to have these specific mechanisms, because often the intervention, the masterful skills are tied to that mechanism. So if you get rid of the kind of weird mechanism, then it really begins to question the kind of specificity of the manual therapy skills and the expertise with an osteopath, and it really does change things up.
I think, yeah, going back to what you said, Rob, on the post-hoc fallacy, I do think that's a large part of it. So the vast majority of osteopaths work in private practice, typically with patients with less complex health needs, higher socioeconomic status and things like that, who are fundamentally going to have a good prognosis regardless. And then we apply that. It worked in my practice. It works for the people who see me, who have the better chance of getting a good result from largely self-limiting episodes of pain. So that was one of the things with the digging deeper into the theory about it, like social determinants of health and things like that, and looking at the wider kind of impact on healthcare, because working in a different population or a different setting, the outcomes are quite different from things beyond L5, slightly restricted on the left, or there's increased tone in the erector spinae. So yeah, there's a lot to it, and very complex and beyond what we did on this occasion, I think. But
I think it was worth. We have written kind of adjacent papers to the What's Wrong paper. One is anatomical possibilism, which explores some of the kind of fanciful connections between anatomy, and the other one that I was involved with was pseudoscience and osteopathy. And there's some other factors which we haven't got time to go into here, but such as the kind of osteopathy, its roots is in CAM, complementary alternative medicine, and in that field, it's kind of a virtue to be open-minded and to think beyond kind of medicine or the traditional kind of mechanisms. So really think blue sky, the whole thing. And so part of that is to be open to these new ideas. And so I think osteopaths who might be enrolling, or students enrolling onto osteopaths, we don't have good data on this, but it could be hypothesized that those enrolling on to be osteopaths may be primed to kind of accept some of these more elaborate ideas because they fly in the face of kind of traditional thinking or kind of kind of standard thinking. So yeah, it's tricky.
And I guess if you've also been subjected to that confirmation bias, you've seen particular manual therapist, osteo, whoever it might have been, they did X treatment and your shin splints went away or your Osgood slatters went away, which possibly regressions to me, no one else could fix it, and then whatever they did fix it, and then obviously it's going to osteopaths are better, and you fit into that. Someone's at someone's mic. You fit into that kind of criteria a bit, and it's maybe that's why you then go to train as an osteopath or whatever manual therapist, and you kind of go down that line. And we've all been trained in manual therapy, and we've all had a patient who we've done something to, and they felt better, and whatever that looks like. And I can really easily see how that you fall into that bias. Oh, it's because of this. And if you don't have those explanatory frameworks in order to justify it, or you're not aware of that post hoc fallacy, then of course it's very easy to fall to that low hanging fruit. And if you want to understand it and want to go deeper into it, then you can. But it's also very easy just to say, oh, we've realigned that, so it feels better, cool, carry on. Because it's much easier to say that, when I don't believe that a lot of osteopaths who are using that language, or chiropractors or physios, actually really believe that joint is out of place. They know it's not dislocated, but it's a very easy language to use when they're talking to a patient.
That's great. And we've got a question in the chat from Thomas saying, "Good talk, gents. I agree with everything you've said. Do you feel there's anything that justifies our continued separate title, or would it be reasonable for us chiros and physios to all become MSK therapists?" So, going into the differences in the explanatory models as well, I have separate views on this myself. I'm not sure is the short answer. So I work in an advanced practice role where I'm not doing a traditional osteopathic role. So essentially, if I had the job title of advanced MSK clinician or advanced practitioner, it's not the traditional role. So we're looking at MDT working to be more about competencies rather than base profession, and that's the way things seem to be moving. There's a lot of issues for osteopaths by not having the same regulator. So certain things like injection therapies, we're excluded from kind of prescription rights and courses and things. So there would absolutely be benefits to it. I very much like that we're a statutory regulated profession. I think that some of the legal strengths we have from that around requesting imaging and bloods and things I can basically do the role I've got because we're a regulated profession. But on a day-to-day for myself, it wouldn't matter what that is. And the more closely I've worked with physiotherapists and chiropractors, the more similar I think we are. Whereas when I was an undergrad, I was told that osteopaths, we are the most holistic, we're the most special in certain ways, we do things differently. And then lo and behold, when I worked with chiropractors, they were told very similar things. They were told rather bizarre things about what osteopaths did, and we were told bizarre things about what they did. And then when we worked together, we did slightly different techniques for manual therapy that were very similar. Similarly to physios, a physio that does manipulations and things like that would possibly work in a really similar way to me. I've worked with physios who were told osteopaths don't know anything about exercise and never do that. And at the time I was teaching the exercise rehab module at one of the osteopathy schools, so I was quite familiar with what was taught to them. So short answer is, I think that's the way things are going. I can see it causing some problems with some members of each profession who their professional identity is really ingrained, and it's really important to them that they are a chiropractor, that they are an osteopath, rather than MSK therapist, which is a bit vague and no one really knows what it means. And would also, to some, limit their scope to just MSK. There's lots of osteopaths who would, and chiropractors as well, who would claim it's more about an alternative way of viewing health and promoting health, that sort of more vitalistic approach rather than limited to MSK practice. So I don't know, it's a really good question. It's the way things are going, and it's a bridge we're going to have to cross at some point, whether we want to or not.
So true. It's so true. It's really typical. I mean, what we're told about different people. I mean, I've seen osteopaths people like, oh yeah, you spend a whole year learning about marketing, don't you? And I was like, do we? Not when I was there. Like, these myths that get perpetuated are really interesting. Ollie, anything to add to that about the kind of the joining of the professions? I know you're much time battery wise. So,
I can't. I've got 4% left. I think it wouldn't. I can't see. I think legally it would be such a big deal, wouldn't it? I mean, to be able to how does that? We've got both Chiro and Osteo AXA since '93, whatever it is. I don't know how you can get rid of those and create a new. I mean, it'd be massive. So I can't see it happening anytime soon, let alone probably not in my lifetime. But theoretically, it could happen because there's so many shared values, shared curricula, shared intervention, all this stuff. It's perfectly reasonable, Thomas, to ask the question, well, what is it? What if you're all kind of different, but there's so much you share? Why do you have three professions? It's like having three different types of dentists, all do teeth, but a little bit different. And it's like, so no, but I can't see it happening. But I think it's a good theoretical discussion to be had. Yeah.
I think that's going to get closer with the uni changes and things like that. So with sort of mergers of higher education institutions, the increased cost and stress on teaching institutions might well have closer working, shared early stages of courses and things like that. But I think closer working is great. But then if it's MSK therapists, who gets left out? Who comes in? Are we going to kind of bring in OT, occupational therapists, where there's a lot of similarity in their work as MDT in a lot of these roles? Like, it's going to be a really tricky one to deal with, and I'm glad it's not me doing it.
Right, last question, I guess. Then I'll direct this to Andrew in case Ollie's laptop dies. 4%. So I guess 3%. The 3%. Oh God, the pushback you had from the paper was I say pushback. The not direct critiques, but in terms of the discussion it forced was a lot in a good way. I like to think. Was there anything which made you query your stance or your thought process, or if you'd had a do-over, you would have done differently? Based on any feedback that you got from the paper?
I'm going to say it before I get cut off. I would say we could just caveat it with, when we made these claims, you suggested all of osteopathy, or it applies to all of osteopathy. We should probably have said some osteopaths or some aspects of the profession or some corners of osteopathy, but we kind of failed to make that nuanced caveat. So that if I would rewrite, but I'd definitely write the paper again.
Cool.
Yeah, I would. And same with the title. We were deliberately provocative, but I've written about 26 papers now, and this one's been read, downloaded, shared more than all of the rest of my work combined, because we went with what's wrong with osteopathy. But we asked it as a question to reflect. So our intention with this wasn't to basically start a big argument. It was to reflect on what we do, how we do it. There's been a fair few criticism for people not familiar with the rest of our work. There's like, that, why are you always so negative? Why aren't you doing anything else? And we've done loads of work to try and promote or develop. So I've recently done a paper on prevention of MSK pain and disability in osteopathy, chiropractic, physio. It's had less than a third of the interest. So, like Ollie said, the caveating it, the explaining it a bit better, but it was a well-intentioned paper that didn't land somehow with some elements of the audience. But at the same time, we've got people reading a journal, downloading papers that probably haven't read a research article or a journal format paper in a long time, getting involved in the discussion, coming to talks about it, kind of, it lit a bit of a fire under some corners. And our view was, well, if you don't like what we've said, write a counterpoint, make the strong argument, do the other thing, like to sort of ignite some action on this of if something works and is good, you should be able to prove it. Unfortunately, we waited about a year and there wasn't a reply, so we did one just to sort of balance things back out. But I'd love to read one from someone else.
Ollie, did you have something to bring on that the last point?
No, nothing, Sam. 1%. I can't believe I'm literally running on fumes here. So I'm going to say goodbye. It's been a pleasure.
Yeah.
Thank you so much, Rob. Thanks, Andrew. And thanks all. Read the paper. You can get free copies on Google Scholar for the What's Wrong paper. MSK Mag, you've got to go on to Substack and subscribe.
Brilliant. Thanks so much for joining us. Have a good rest of your day. Please answer the poll, which is popping up on your screens shortly. And I look forward to seeing you at the rest of the afternoon. Have a great Therapy Live day, everyone. Thanks both.
Thanks everyone for coming.